Welcome, and thank you for joining us today. My name is Jennifer Schaefer, and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some quick information on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. We will have a panel discussion following the presentations. We recommend going to the View menu option in the upper left-hand corner of your screen and unselecting Show Participants Without Cameras. This way you will not see my name appear. You'll just see everyone's pretty faces for the panel discussion. Please submit questions throughout the presentation and panel discussion using the chat or Q&A feature and select all panelists. I will be collecting those and passing them along to our moderator, who will help facilitate those on your behalf. If you require technical assistance, please feel free to contact me, the host, via the chat panel, and I'd be happy to assist you. If you need closed captioning, a link will appear momentarily within the chat box. I wanted to note that today's presentation is being recorded and will be available online within 1 to 2 weeks. We will be sending out communication once available. And now I'd like to turn it over to Nona K. Shelburne to introduce today's webinar and our speakers.
Thank you, Jennifer, and thank you to everyone for attending today. I want to give a little background before we jump into our topic today, which is titled Uncovering That Which is Hidden, Measuring the Effects of Racism in Research on Inherited Cancer Syndromes. Next slide. In 2016, the Blue Ribbon Panel sent out a recommendation that NCI should sponsor initiatives that improve the current state of genetic counseling and testing, the prevention and early detection and knowledge landscape for those with inherited predispositions. Next slide. With that, our team at NCI, across the Healthcare Delivery Research Program, Epidemiology and Genomics Research Program, and Behavioral Research Program, developed several funding announcements to focus on how we can improve care and focus on this recommendation. Next slide. So to do this, we created some funding announcements that focused on studies and strategies that would increase case ascertainment for probans and at-risk relatives at high risk for cancer, and improve delivery of evidence-based services across several domains, including genetic counseling, communication strategies, decision-making around preventive and early detection services, and ongoing surveillance. So with these initiatives, we funded 12 UO1 grants and 2 R01 grants. And I've also partnered with PCORI, who funded one study that also falls within this domain. Next slide. And those 15 studies created the Inherited Cancer Syndrome Collaborative, and the ICSC is what is presenting this webinar today. And this goal of this collaboration is accelerate our research on the early identification strategies to improve outcomes in inherited cancer syndromes. In the bottom right, you see a map of the United States, and everything in turquoise and green represents the counties in which the different studies are recruiting participants. And the light green shows the rural expanse of these studies, trying to make sure we're identifying strategies that work for all populations. So we recognize that the potential impact of structural racism and health disparities have on these intervention and outcomes that are being studied, and we really need to discuss and identify methods to capture this impact. And this in turn would improve our understanding around these interventions as they're developed and they're implemented. So today's webinar is really focused on that, and to have a nice open discussion about how we can move this field forward while capturing all the components that are affecting our interventions. So I'm excited to hand this over to our wonderful moderator for today, Dr. Kim Kappings, who's professor in the Department of Communication at the University of Utah. Kim?
Great, thank you. It is my pleasure to introduce our speaker who's going to give introductory comments, Dr. Debbie Cragen. Dr. Cragen is an assistant professor and director of the Genetic Counseling Graduate Program at the University of South Florida. Her research has included studies describing differences in genetic counseling access and service delivery across racial and ethnic minority groups. She is currently a multiple PI working alongside Dr. Tuya Pale, who I will be introducing you to later, on one of the funded UO1 grants that is part of the ICSC. So I will hand this over to Debbie.
Thank you, Kim. I appreciate that introduction, and thanks to all who have taken time out of your busy schedules to join us today. I want to begin very quickly with a brief story. I was preparing my slides and finalizing them last week, and I asked my husband, who's a sociologist, what's the most commonly accepted definition of racism? He asked me, why are you asking me about this? So when I told him that I was doing introductory comments for this webinar, he said, who on earth would ask a white woman from Utah to talk about racism? And we talked a little bit more about this, and he thought I was crazy because I did volunteer, given that I was one of the people who came up with this topic. But we talked about it, and we both agreed that everyone, whether they have lived experience or whether they're an expert in this topic, really needs to talk about these things if we really want things to change. So I'm going to provide an illustration with my own research. And like many other researchers, we found that young Black breast cancer survivors and young Spanish-speaking breast cancer survivors are less likely than their non-Hispanic white counterparts to have genetic testing. We also found this same pattern when we were asking about whether or not they discussed testing with their healthcare provider. So we looked a little bit more at this, and we wanted to see what was the impact of some of the clinical risk factors, as well as some of the socioeconomic risk factors, and we did a path analysis. So you can see several of these factors were statistically significantly related to whether or not they discussed testing with a healthcare provider. The paths that I'm showing here, even though they were statistically significant, had odds ratios less than 2 unless shown otherwise. So as you can see, what stands out most is the non-Hispanic whites were 14 times more likely than the Black individuals to have discussed testing with a healthcare provider. And we can also see that non-Hispanic whites are about twice as likely as our Spanish-speaking participants to have discussed testing with a healthcare provider. When we look at receipt of genetic testing, we can see a lot of things that are impacting this. And once again, we can see what's kind of standing out. We also have a disparity between Black and non-Hispanic white there. But by far, the strongest correlate with having received genetic testing is whether they discussed testing with a healthcare provider. In our discussion in this article, we acknowledge that other unexplored potential explanations for observed differences could include provider characteristics and distribution. And luckily enough, there was another paper that looked at some of these factors. Their findings, they also found there are some clinical risk factors that were associated with testing, which we would expect because some people are at a higher risk based on those factors. They found that in their multi-level model, socioeconomic factors were no longer significant. Attitudes about testing did remain statistically significant, but when we're looking at surgeon and oncologist characteristics in the level 2 of their model, they were not significant. They did show that Black and white women tend to see different surgeons and oncologists, so there is healthcare segregation happening. However, based on their statistical modeling, that was not associated. So what was? Physician recommended testing again. That was the strongest correlate of whether or not they had genetic testing. So after seeing that, you can go, okay, so what's left? So in what we wrote, we have this and clinical practice situations. Honestly, I'm not sure what we meant when we wrote that at the time, but I am a bit disappointed now looking back that we did not mention implicit bias as a potential explanation. I don't know if we were trying to stay away from a topic that can be controversial, or I do know that we wanted to focus more on some of our other findings that were more novel, but still, this should have been discussed if I had to do it again. So thinking about this, I went, how many people really do discuss this though in their articles? So I did a search on PubMed for implicit bias and genetic, and I found 10 results. One of these I really appreciated because I train genetic counseling students, and if we cannot uncover what is hidden in our own practice, we're not going to be able to change it. So I appreciate that these researchers pointed that out in my own field of practice. As I was reading through various things, I found a blog that I would recommend you to read, and it's listed here. One of the quotes I loved from it is that journal articles routinely fail to interrogate racism as a critical driver of racial health inequities. And that was salient because I had failed to do the same. So I wanted to think a little bit more about structural racism. And in doing my search for structural racism in genetics, I found 13 results. One of them was this article. And this is a great article because it got me thinking about, in our study, we didn't find that where people are treated was what was making the difference in whether they had genetic testing. But I know of another example where this is the case in hereditary cancer. Where you are treated makes a huge difference in whether or not you are getting your tumor screening for Lynch syndrome if you have colorectal or endometrial cancers. And early on, we had unequal adoption of these screening programs, with NCI Comprehensive Cancer Centers being more likely to adopt them. Adoption is still unequal. There's still a lot of places that have not implemented this. We're working towards this, and I'm hopeful that as we implement this across more widely, we're going to get rid of that disparity in identification of individuals with Lynch syndrome. And this was hopeful. Across these 4 academic medical centers, tumors from 92% of their colorectal cancer patients were indeed screened for Lynch syndrome after they implemented this systematic approach. So that was exciting. But what they found is that there's still a difference in terms of genetic evaluation referral rates based on race and ethnicity. And when they did their multi-level model, they found that factors that remained negatively associated were Black, older age, and medical center. If you read through the discussion, you'll also note, they also note that the individuals who were Hispanic were almost all treated at a medical center that had very low referral rates. So even though that did not stay significant in their multivariable model, we do see the systemic issues that are playing a role, and where you live may impact your care. So I'm going to finish with a quote here. Despite exploring potential societal or systemic drivers, the term racism is never mentioned. And again, that came from the same blog. So the last thing I put into PubMed was systemic racism and genetic. And when I did that, I only got 5 results. But cool enough as it is, one of these results was our speaker today, Kyle Brothers. So I want to thank you all for coming and turn it over to Kim, who will introduce our speaker.
Great. Thank you for the great introduction to Dr. Cragen. So thank you all for joining us. It's really thrilling to see this many people on. And just as a reminder for those of you who have joined us, please do type comments or questions into the Q&A box, and we will be hoping to have a discussion after Dr. Brothers speaks with the panel. So let me go ahead and introduce our speaker. Dr. Kyle Brothers serves as Chief Scientific Officer for Norton Children's Research Institute in Louisville. He is an Associate Professor of Pediatrics and the Endowed Chair for Pediatric Clinical and Translational Research at the University of Louisville, where he also directs the Division of Pediatric Clinical and Translational Research. Dr. Brothers is a pediatrician and a bioethicist who conducts research on ethical issues in the translation of genomic technologies to clinical practice. And he is also a practicing primary care pediatrician and serves as a clinical ethics consultant at Norton's Children's Hospital. So I am very much looking forward to your comments, Dr. Brothers.
Great. Am I unmuted now? Great. And thanks to all of you for being on this call. And that was a great introduction. I did want to recognize my co-authors on that paper, Mildred Cho and Robin Bennett. The three of us are editors at Genetics and Medicine, and that paper that we wrote really came out of our work at that journal to think about what can the journal do in order to really bring to the surface this issue that, as we've said, is often hidden about the role of racism in health outcomes. And so I wanted to talk through some of these issues with you today. I don't claim to be an expert on this topic. I certainly care a lot about it. And I hope that this will help set off a conversation that because I'd love to get feedback from all of you. And I'll just say some of the recommendations that I'm going to set out during this talk come from that paper that Robin and Mildred and I did. So first of all, just to define systemic racism, in many ways, systemic racism and structural racism are used as synonyms. I think you could probably identify some subtle differences, but in general, they mean the same thing. And I like this definition from the Aspen Institute. Systemic racism is a system in which public policies, institutional practices, cultural representations, and other norms work in various and often reinforcing ways to perpetuate racial group inequity. And, in this context, the racial group inequity that we're interested in is perpetuating health disparities, right? Health disparities are not hidden. We hear about health disparities a lot. The problem is we too often stay at just saying there's a disparity, and we don't ask the question, why is that? So there are a number of ways to think about systemic racism and its effects on health. I really like this model. This is called the house that racism built. And it really, we're trying to lay out, a conceptual model, a picture that summarizes where we think the connections are. And what I love about this image is that it really demonstrates how racism operates in lots of different ways. And the way to think about it, I think, is that, racism sits behind a lot of this. It's sort of not overtly visible, right? We try to avoid racism. That's why in a lot of articles that address health disparities, no one ever uses the word racism. But racism operates through mechanisms, right? So there are mechanisms like income disparities, housing disparities, individual discrimination that then influence health outcomes. And so I think this model really does a great job of showing some of those connections, and it helps us start to think about the disparities that we're interested in this case with heritable cancers, and thinking about where could racism be playing a role there. I just included this slide. This is from Kamara Jones, and this article is really brilliant, and I would highly recommend everyone reading it. This is the model that she presents, and just another way to think about these effects. I don't think it matters too much about the model that you use, but I do think it's important when you set out to design a study where you think, I'd really like to figure out how racism is operating in this domain that I'm working in. Starting with a conceptual model like this can really help you start to identify what's the approach I'm going to take in the study to identify the mechanisms by which racism is operating. It's hard to measure racism directly, but we can measure its mechanisms. And specific to genetics and genomics research, there are some issues unique to this field. As I was saying earlier, a lot of the work that we do in our field too often concludes with this question, there is a disparity, and this is from Kamara Jones's article, am I going to try to understand those differences? And often our answer is no, I'm not going to try. So what we do is we document that difference, and we, without really analyzing it further, maybe at times we adjust for race to control for confounding, treating race as if it's a confounder. And sometimes we restrict analysis to a single race. You all are likely aware in the early history of genome-wide association studies, almost all the studies were done with European populations because the decision was made, we're not going to dig any deeper into this issue. We're going to restrict the analysis to a single, in that case, ancestry category. But too often we use these shortcuts in order not to delve any deeper. And what I really want to push in this talk is we really need to move away from this approach to science. We need to say identifying a disparity is not enough. We need to identify why that disparity is taking place. I wanted to show a few examples of papers that have dealt with this, and not in a critical way, but rather just to show how this work is being done and lead into a conversation about what we want the future of our field to look like. So barriers to the use of genetic testing, a study of racial and ethnic disparities. In this paper, they measured patient knowledge, patient concerns about misuse. So this is a really common way to sort of get at race without getting at race. It's measuring the concerns or the mistrust of participants or patients rather than the factors that made those folks develop mistrust. Health insurance coverage, which is a that's common in health insurance to use, or health research to use insurance coverage as a proxy for socioeconomic status, because it is often the only data available in the medical record that you can use. And then patient trust in the physician, again, looking at the patient or the research participant's trust rather than the factors that brought about that mistrust. And again, there's nothing wrong with the study. It does touch on income, using insurance as a proxy. And it looks at psychological responses to individual discrimination, but only at the response. And, there's nothing wrong with this model. But as you can see, there's only a few topics touched on here. This is another really excellent paper that you've already heard about today. Racial disparities in BRCA testing and cancer risk management. And the measures in this study focus on rates of risk-reducing surgery and the provider discussion about genetic testing. So this is also, a great step forward because it really looked at the provider's choice about whether to discuss, which is a form of implicit bias. And instead of sort of victim blaming and focusing on the mistrust of the patient or the participant. But again, this is a rather focused lens that we're reviewing racism with. And it would, the goal is to expand that lens, I think, in order to maybe account for more of this. I do want to warn, however, against the kitchen sink model, which would be, let's just measure everything. Let's, look at every single possible mechanism that racism could be operating and just cover it all. And there's a couple of reasons that I think that that's problematic. First of all, it's not practical because there are too many variables. Some of those have to be elicited directly from the patient. And of course, you have the burden of filling all that paperwork out for the participants. So in many ways, it's not practical. And also, I think it's important to point out that in some ways, it's not scientifically valuable to gather all that information, because in many cases, we're talking about minoritized groups that are not in the majority. And there's rarely a large enough sample size to sort out relationships. So you really have to find kind of a middle ground where you're not doing everything, but you're also not limiting yourself to a view that just focuses on interpersonal discrimination, for example. And as I've said, I hope this is really driving home. Just documenting health disparities is really not enough. So what I would propose is really starting with the House That Racism Built or some other framework, and think about the health disparity that you're interested in your study. What is the difference created by race that you want to understand why that's happening. And then, as we said, you can't measure systemic racism directly, but what you can do is look at the mechanisms by which racism operates and create a conceptual model that will explain for yourself what your hypothesis is about what are the mechanisms that are bringing about this disparity. There's well-known research, for example, about survival in emergency rooms of patients with heart attacks and how there's a racial disparity there. So you can start to think about what are the mechanisms for that particular disparity that might work, like time to arrival at the hospital. You could think about maybe there are some housing issues that may influence that. There may be economic issues, insurance, things like that. So what you want to do is create a hypothesis. This is what I believe is the effect, and then build that into your study. That's what you want to measure. And then ultimately, I'm not a statistician, but of course you're going to want a statistician to help you think about the plan. How do I understand the relationships here? And when you do that, of course, it's going to be important using almost any methodology that you're going to use, that you're going to need to oversample within racial groups. One of the very unfortunate effects of systemic racism is that folks within racial groups tend to have similar socioeconomic status and other measures. So it's important to oversample in order to get as much spread there as you can. That's really helps you start to uncover the mechanisms by which racism works. Another way in which genomics is, and genetics in clinical settings is slightly different, is that we have this specter of genetic ancestry that sort of influences the way that folks in genetics think about race, right? While there is a statistical correlation here between ancestry and sociopolitical classifications around race, they're not as strong as we often assume they are. And I'd love to talk with you all about that sometime. That is its own super interesting story. But the important thing to remember is ancestry and race are not the same. They should never be used as proxies for one another. And we have to design our studies explicitly that look at genetics in order to account for that effect. So I just want to drive home these definitions. Race is a socio-political category, right? It's formed within social and political structures. Genetic ancestry is a representation of where an individual's ancestors might have originated. Again, it's not necessarily ground truth. It is a representation based on genetic data, right? So they have very different meanings, and but they're not perfectly correlated, actually nowhere near perfectly correlated. So it's very important to separate them and not confuse yourself when designing your study about which is which. I wanted to give this one example. I know this is not a cancer-related example, but I hope that this will really drive home the message. I was taught in medical school by my professors that the reason that there is a disparity in hypertension among adults, Black individuals and white individuals within the US context, there's a stark disparity in hypertension risk between those two groups. And I was told that that is due to selective pressure that was created during the Middle Passage. That's the slave trade from West Africa into the Caribbean and the US, which led to disproportionate survival among individuals that created a genetic predisposition to hold on to salt, okay? I remember very clearly being taught this, and with a lot of confidence about the genetic factors here. It turns out no one has ever uncovered any genetic evidence to support this claim, okay? So how is it that a story like that could be carried forth with such belief when there's really no evidence to support it, right? The point here is that because we start to confuse race and ancestry, we start to biologize race, right? We start to think of race as a biological reality. And when we do that, we tend to focus on possible biological explanations instead of focusing on socio-political explanations about the way racism operates in our society, right? We, for lots and lots of different reasons, tend to hide racism and its effects. And so in the field of genetics, when we start to focus on biology and possible biological differences between populations, we start to hide even, more significantly the role of racism. So the key is pull out racism, understand its effects, and not get into the error of biologizing race excessively. Okay, so these are just a few quick guidance or like recommendation types of things, and then I'd love to move into discussion. So race should be included in studies. We should not think about race as sort of like, oh, we're in a post-race era, we're not measuring race. We really need to measure race. We need to use self-reported race as a rigorous way to measure race. And it should be included in studies focused on healthcare delivery, the etiologies of medical conditions and health outcomes, aka health disparities. So we really want to include race in order to explain those kinds of things. We should look at genetic ancestry, especially when we're talking about the effects of genetic variation on health. And in studies that are touching on both of those topics, we want to measure both separately. They have separate meanings. But when you're publishing and discussing these findings with your colleagues, you really want to make sure you're explaining why, what my intention was in measuring race, what my intention was in measuring genetic ancestry. This is something that blog post by Rhea Boyd and her colleagues really, I thought, said very eloquently that it's important to be explicit about why race is being used. And then just because this comes up a lot and we wanted to throw out some starting point for discussion, the question is about what kinds of terms we're supposed to use. And the recommendations that Mildred and Robin and I set forth is that specific to genetics, which has its own kinds of complexities, we really think terms that obscure the distinction between sociopolitical race and genetic ancestry are problematic. And so therefore, we really have to avoid those terms. So even though African American has been used for a long time as a synonym for Black, in the context of genetics, we actually confuse ourselves when we start talking about African American because it starts to sound like an ancestry term. So we really think in genetics, we should be saying Black and white, not confusing ourselves by referring to ancestry. And the term Caucasian is particularly problematic because that term is itself rooted in historical conceptions of race as a biological category. So we definitely want to not use that one. And then it's important to the extent possible to try to get away from using large umbrella terms like Asian and really get more focused in terms like Japanese, Indian, Chinese, or even maybe more specific than Chinese. And this is important because when there are health disparities internal to these big umbrella groups, we sometimes miss them. We miss those disparities if we don't break the groups down into more specific categories. So just some thoughts on that issue. And then finally, as Deborah was really, I thought said very eloquently, we have to name the problem. When we're reporting on the, correlation between incarcerated parents and a particular health disparity, we don't stop there in the discussion of our paper, right? We have to say, we measured incarcerated parents, but it's important to note that differential incarceration is driven by systemic racism, right? We have to say words like systemic racism because choosing not to say them is really hiding the problem, right? And we don't want to do that. Okay, that's all I had on my slides. I look forward to the discussion.
Great. Thank you so much, Dr. Brothers. Really interesting and thought-provoking talk. So what I am going to do is introduce our discussant, Dr. Sonia Reed, and then we will move into a panel discussion after Dr. Reed's comments. So a number of you have started typing in questions or comments for the panelists. Please continue to do so. And we have a couple questions. This is being recorded and the recording will be shared in a week or two for those of you who are interested. But please keep the comments coming. So next, I would like to introduce Dr. Sonia Reed, who is our discussant for today. Dr. Reed is an assistant professor in the Division of Hematology Oncology at Vanderbilt University Medical Center. Her research focuses primarily on health disparities in breast cancer, young onset breast cancer, and hereditary breast cancer. Dr. Reed is also focused on improving healthcare delivery to underserved communities and increasing the representation of minority patients in clinical trials. She recently completed a Master of Public Health degree from Vanderbilt with a focus on global health. And Dr. Reed recently received the Martin Luther King Jr. Award in recognition of her work in diversity, inclusion, and equity at Vanderbilt University. Dr. Reed, I will turn it over to you for your comments.
Thank you, Kim, for that introduction. Just sitting here, just taking it all in. Great talks, both Debbie and Kyle. I really enjoyed the discussion that I think we'll definitely get out of this. Just few thoughts that came to mind, especially from the last talk where Kyle mentioned, a lot of times in this space, we always try to figure out, when we think about barriers to recruitment in studies or barriers to patients being tested, we tend to say, okay, the patient is the problem. The patient did not trust the system, or why did the patient not engage with the doctor? And I think we really sometimes have to broaden our scope and say, as providers in the space or the system, what is it that the system, what barriers did the system put in place, or what barriers or blind spots or implicit bias us as doctors and treating these patients are missing, right? Why are we not equally recommending or referring patients for germline testing when indicated, as was eloquently stated by the study that Debbie mentioned? We see that providers lack of provider recommendation has been consistently shown to be a barrier, and of course that's across different racial groups. So one thing, if we saw that there were it was equal across all racial groups, but when you're seeing that there are differences, it makes us stop and wonder, why are we recommending one racial group for genetic testing more than another? And I think those things really have to make us stop and pause, and it may just be a blinder that we may need to just stop and figure out, why is this happening and what can we do to move the needle forward? That way we don't keep doing that going forward. And on that note, something that's dear and near to my heart when I think about this is when you think about research and clinical studies, not just clinical trials broadly, but for the scope of this talk, when you start thinking about targeted therapy trials, I think when we are looking at data, the data is going to it's going to be as good as what we pulled into the data, right? So if we're not testing patients uniformly across different racial groups, then we're going to have a body of work that's really not representative of our population, which then goes out into having therapies that are now approved for drugs, targeted therapies, but not representative of the entire population. And I think we always have to remember that fact, that we're in the end, especially, as you heard from my introduction, being a medical oncologist, that's something I think about long-term, for example, with our BRCA carriers, when you think about getting into PARP inhibitors and trying to improve outcomes for these patients. If we don't have patients that are enrolled in these genomic databases because we're not testing them, then we're not going to have drugs that are tested in a representative sample. So I think that's something that I think we just have to be mindful and make sure that we are doing better for patients.
Wonderful. Thank you, Dr. Reed. A great way to kick off the discussion. Interesting comments. And what I would like to do is just introduce our last panelist and then turn things over to the discussion that's started to happen already in the chat. So Dr. Tuya Pal is a professor of medicine and an Ingram Professor of Cancer Research at the Vanderbilt University Medical Center, where she is also the Associate Director for Cancer Health Disparities at the Vanderbilt Ingram Cancer Center. Her work has focused on inherited cancer risks across basic and clinical services, as well as health services delivery, including efforts in underserved populations. So I have a number of questions from the audience, but first just wanted to see if any of the panelists had a comment they wanted to start with or something that came to mind as you were listening to the talks. Otherwise, I can start sharing comments from the audience.
Yeah, Kim, so I just wanted to comment on Kyle's presentation, which, you know, again, Debbie and Kyle, great job on the presentations. Now, with Kyle, I agree with you, Black versus African American, right? So there's the issue of ancestry, but there's also an issue of like, who do people who are Black identify as in the US? And I'll say, you know, this was a long time ago, probably 10 or 15 years ago. We had done a study, myself along with my colleague, Dr. Vada Prampel, when we were in Florida, and we did focus groups to kind of talk about, okay, well, what should we be using? What term should we be using in our brochures? And the main message, and we tried even to use women of color. Women of color did not work because, you know, what color, you know what I mean? Like it wasn't specific enough. African American, especially in Florida, it's a diverse population of Blacks. So a lot of them don't identify as African American. And I think Sonia could attest to that. So again, I think Black is a much more inclusive term, and it also enables people to understand what category we're trying to capture. So I think that's one thing. The other thing is, I completely agree with you, Kyle, with, you know, how are we classifying like some of these big umbrella categories? Asian, I mean, I'm Asian, but that doesn't give you, like, there's so many different Asian populations that I'm not quite sure what it's capturing when we have the US Census that's just classifying everyone from Asia as Asian. And again, I know part of this whole effort is to kind of think about, well, what should we be capturing across our studies to get the most useful data possible? So again, I think that would be one thing that we should really think about. And then, you know, just talking about Sonia's excellent comments as well. So the issue of genomics, right? Like we know that most of our data from GWAS studies is from whites. So it's about 80% of GWAS data has been generated in whites. Yet we know that when we use the data from whites to predict what's going to happen in other populations, it's not a great predictor. The estimates I've seen is about 25% prediction accuracy in Blacks, about 50% in Asians. So again, there's a problem there. But beyond it being an ethical issue, we're also losing out scientifically, right? Because when you have diverse populations that are enrolled in these genomic studies, you actually win scientifically because, again, Africa has the most diversity because it was a population from which all human populations originated, right? So again, you can actually measure this where the GWAS studies, like when you look at associations, African Americans represent about 2 or 3% of individuals included in GWAS studies, but they actually represent about 7% of associations that have been identified. So it's both an ethical and a scientific issue. So I think an excellent point by Sonia, but it's really important for us to think broadly, because if we are more inclusive, I think we all win.
Yeah, and I'll just say, completely agree with you about the difficulty of using categories that folks will identify themselves with, while at the same time trying to avoid reinforcing kind of confusing uses of terms. And we've struggled with that at Genetics and Medicine as we've thought about how do we, folks are using data sets, some of which maybe might be census data, might have been collected, previously, months or years ago. And we don't want people to take a data set in which folks self-identified as African American and then say, oh, that's a Black category, because again, we have to use the data as it was collected. We don't want to make inferences about how people would have identified had we given them different sets of terms. So I really think there's the scientific issue here is very complex. So I think the way we're thinking about it at the journal is that, if you collected data using a set of terms, you should use those terms. But if you are then stepping away from your empirical data and talking about, more conceptual kinds of categories, you really should switch over to something that is, avoids kind of problematic terms.
Looks like there might be some technical difficulties on Kim's end. And so while we're waiting on her to come back, wanted to look at some of the questions that we have coming in. And one simple one, Debbie, is there a link that you can provide and share in the chat about the blog that you recommended everyone look at?
Yeah, I'll go ahead and pull that. Thank you.
Thank you. That's great. Specifically for Dr. Reed, someone said, isn't research to validate founder effects in certain populations should be the trigger for this targeted genetic counseling?
And while I totally agree that we need to be doing research focused on founder mutations, et cetera, I think we still need to make sure that we're identifying patients when indicated. So not just focused on finding founder mutations, but also trying to increase our representation of patients once they meet the criteria for testing, period, right? So once a patient meets criteria for germline testing, we need to make sure that those patients actually are referred and are tested for us to then understand and learn from those patients' patient differences as well, is what I would say.
Thank you. Another question came out, if Black, Indigenous, people of color patients aren't being referred appropriately for genetic testing, how can genetic counselors combat this and reach these patients? This person imagines this question can be answered at a variety of levels, but would really appreciate your thoughts from the panel. Tanya, do you have any comments?
I'm sorry, could you repeat the question?
Sure.
My apologies.
Just talking about if we're trying to reach these populations such as Black, Indigenous, and people of color, and they're not being referred appropriately to genetic testing, what can genetic counselors do to really reach these patients? And how can we answer this looking at a variety of levels?
Yeah, I think sometimes we need to maybe think outside the box, trying to go to those patients. A lot of these patients are not in big academic centers where a lot of us are. So we need to make sure that whether that's academic community partnerships, telehealth, trying to make sure that we have resources for some of these patients that are not able to come to the bigger centers, I think would be definitely important.
Debbie, do you have any comments on that? Coming from the genetic counseling world?
Yeah, I also think we definitely need to diversify our profession and ensure that we have even more genetic counselors who can, say, speak Spanish so that we can reach that population as well.
Anyone else on the panel?
The other place where I think we can make that's a huge opportunity is leveraging information technology or leveraging the EHR, because the EHR is not going to differentiate other demographic factors, right? Like if there are ways of leveraging technology to identify these people, I think that would be a really great way to start. The issue then becomes, once you identify them, even from identification to actually getting the services is still not automatic. So navigating them through that process is also important. But identification, we even know, like across all populations, we're not doing very well, right? Like 25 years after identification of the BRCA genes, only a small fraction of our population, adult population, has been tested and identified to have a BRCA gene mutation. And it's just worse in underrepresented populations, but it's a problem all the way around.
And Nanake, I am back. Sorry about the technical difficulties. Thank you for filling in. Kyle, did you want to add to Tuya's comment?
Actually, I wanted to, there's some discussion in the Q&A that I think we could kind of pull together, because I would love to hear the panelists what they think about this, which is the question about populations, groups of folks who might have African ancestry or identify as a group associated with Black, but are not African American, so to speak. So Sonia, I think you have some insights on this that I would love to hear about being Afro-Caribbean as a group and using these other kinds of identifiers.
Yeah, definitely. I think it's something that I think about not only from an ancestry standpoint, so scientifically it can be dangerous when you start ascribing to just calling someone African American when they're not. As you mentioned, myself, I'm originally from Jamaica. So it not only is your ancestry different, but your lived experience is also different. So when you start thinking about just the mistrust in the system, for example, and just differences from just growing up, right? Your beliefs in the medical system and how that then transported to how you actually interact with the medical system will differ. But on the other hand, when I think about ancestry, I always go back to this study that I think Lisa Newman did, where she looks at breast cancer, triple negative breast cancer patients. And when you look at patients from West Africa, they have high triple negative rates, which is, as we all, some of us on this call may know, it's very aggressive, right? An aggressive type of breast cancer, more aggressive than the other subtypes. But when you look at triple negative rates in West African countries, it's sometimes up to 30%, versus in East Africa, countries like Ethiopia, for example, the triple negative breast cancer rates are low, similar to European or white patients rates. So then you realize those patients, if you look at them, they're both Black patients, right? But just differences in just how coming from East versus West Africa, even your risk of an aggressive breast cancer differs. And I think that's why I always prefer the terminology Black and then delve into what is your ancestry to figure out what differences from a risk standpoint that plays into.
And I did want to signal our colleague Alice Popejoy has done some work that you all might want to look into. I think she has some really great thoughts, and there's numerous articles that she's done with her colleagues. And I think one strategy that you could use is to just ask folks to identify, like an open-ended text box kind of thing. The problem there is really you face difficult decisions about how to collapse categories, right? So you're always kind of balancing, trying to be genuine to what a person would identify themselves versus coming up with groupings that, as Sonia was pointing out, kind of carry medical significance, biological significance of some sort, and also socio-political significance, because folks have different lived experiences related to race. So I think there's no clean answer to that. That's part of the reason that we have conversations like this. But I think there's a range of approaches, and you really have to balance the strategy that you take depending on the problem you're trying to solve and the population you're working with.
I think just to add, there was a related question on supporting providers that I thought we could ask and just add into the conversation here. So one challenge we've encountered in our work is how to be transparent about differences in risk based on ancestry and how to support doctors in identifying how data about ancestry applies or does not apply, since they often only have access to socially constructed race. Particularly since a large proportion of Americans, particularly Black Americans, do not have knowledge about their ancestry due to the history of erasure in our country. So any thoughts that anyone wanted to add with that question?
It's a brilliant question. I don't know if anybody else wants to jump in. It really is very challenging, and I think Sonia was really pointing out a really nice example where ancestry has a medical relevance, right? A clinical relevance, but we don't routinely have ways to identify ancestry. And I think, again, there's probably a couple of different strategies you could use depending on the circumstance. One way, which I think this audience will probably be all for, is instead of making assumptions based on race category or even ancestry category, looking at the specific genetic variant that matters, right? So that's one way to really get away from trying to provide clinical guidance based on guesses about ancestry or biologizing race, to instead say, well, what really matters is this genetic variant or this set of genetic variants. Let's just test for them and not base clinical care on something so unrigorous, the way that we categorize folks.
Well, going back to categorization, kind of related is, how when we say someone is Black or African American, well, they could be mixed race. And like, why aren't we then saying, well, they're white? Right? And I'll just give the example of Barack Obama. He is half Black and half white, right? But yet we call him our first Black president. So that kind of confuses me. And I don't know, like when we're talking about self-reported race, I think giving people a bit more guidance on what exactly that means. I mean, race truly is a social construct, right? Like that in and of itself kind of proves it. But I don't know, Sonia, what are your thoughts?
Yeah, no, I agree completely. And that's why I think it's so important to, it's difficult, right? And I love that example with Barack Obama, but it's true. They always say from someone, I don't know, 2% Black, then you're Black, no matter how small that contributor is, right? And then that drives home the social construct, because you're right, that person, even though from maybe a germline standpoint, they have more non-Black genes than, for example, if you want to say it that way. Just how they are interacting with their environment, it's going to be one of how a Black person interacts with their environment, right? And I think that's a lot of the times why sometimes it's ascribed, well, they're Black, right? Doesn't matter, which just makes it complicated. It's complicated.
Any other thoughts from the panelists? Otherwise, I can pose another question on a somewhat different topic, but a couple of questions have related to the issue of genomic data. So in the world of genetics, we keep talking about the lack of genomic data for individuals from underrepresented populations. What do you see as the pathway to fix that problem? Who should get involved? Who are the key players? Who should fund it? So any thoughts from the panelists on improving the genomic data from underrepresented populations?
I think we have to be intentional, right? We have to go
Also
up.
has comments as well. So, I think there are some concerted efforts now in Africa, like in collaboration with the US, to increase the diversity of genomic data that we have. I think increasing the awareness is also important, right? Because yes, it's absolutely an ethical issue. It's also a scientific issue. Again, just couching it in that way and making people aware of that, I think, is super important. You know, we have more diversity, everyone wins. I think that's clear, like all across all populations. And then from a clinical trial standpoint, again, I think there has been a concerted effort on the part of industry to increase diversity in enrollment in clinical trials. And Sonia has actually outlined this in a nice piece that she had done for the ASCO Post, where when you look at populations of African Americans like that get breast cancer versus the proportion of breast cancer patients in clinical trials, there's a huge underrepresentation. So what, like, drugs are approved based on primarily data from whites. And again, that is a missed opportunity to really refine these drugs and test them across all populations, for everyone to be able to benefit. But I do think there is a push for more inclusion. On top of that, even reporting in journals. In the past, we've found some articles where, you know, they stated 5% other race, but then we don't know what the other race is. So again, having more stringent criteria with reporting race, and if it is 1% African American, at least letting us know that so that we can call it out and try to do better. But Sonia, I'll give it to you because I know you have some thoughts on this.
Yeah, that's fine. Yeah, no, I think we have to be intentional in our recruitment. We have to think about, as Sue had kind of alluded to, in context, right? So if we're thinking about, I'll use breast cancer example, thinking about breast cancer, for example, the population of breast cancer patients, we know about, say, 13% of the US population are Black patients, so to speak, give or take, right? That's what our clinical trial should look like. And the same thing in our germline studies. We need to make sure that we're intentional, setting stringent criteria at the onset of these trials, right? Where we are setting those benchmarks. We are going out intentionally to recruit this amount of patients from X and Y background. And once we meet that quota, we then, you know, whether it means we open up the trial at another site that has that diverse population that we're looking for. I think we kind of really have to be intentional, and this is what we're looking for. And we won't move on with the study until we meet these benchmarks. And I think part of the question mentioned, you know, for funding or who would, you know, support these trials. I think everybody, all of us need to make this a priority, from industry to, you know, cooperative group, different entities. I think all stakeholders really need to be on board, because I think this gives us better data for our patients, right? We are able to truly understand different tolerability, efficacy of drugs, and understand the science, which is, you know, what, you know, us here as researchers get, you know, very excited about, truly understanding what we're studying to move the field forward.
Yeah, I completely agree with you, Sonia. And I just wanted to throw out the term community engagement, which gets sometimes engagement. It's not clear exactly what we mean when we say engagement, but just to not to be too generic, we'll say that, you know, folks in minoritized groups are often have a very rational response to the long history of both individually and their population and experiencing discrimination in healthcare settings, and that is not going to be overcome by, you know, we take all comers. You know, you really have to go out, work with the groups that you're trying to recruit in order to try to address that the mistrust that has been created by this history of discrimination and racism. And so really, you know, the system is not going to get rid of that for you. You have to go out as a researcher and work with those groups, create relationships, and build that trust. And I think that is the way to help, what, as Sonia said, combined with partnering with other sites that are able to recruit those populations where they have built trust and where they are working with those communities. So just another piece of that strategy.
Great.
And the other thing I'm going to just add to that is the study that Debbie had mentioned, our study in, it was across Black women, but also whites and Hispanics. But when we started out with our efforts in Black women, and this was, 15, 20 years ago, we were told Black women were not interested in genetics. And that couldn't be further from the truth, because we did not have trouble recruiting these women, and these women were really thankful to be in this study. So I think part of it is making it easy for people, meeting people where they are in order to get the care they need or get, participate in the research they need. I think part of the reason we were able to recruit to the level we did is because we made it as easy as possible for people to participate. And again, as we embark on recruitment for our U01, we have those learnings in mind to really try to, enrich for minority populations, but also not make it burdensome. And when you do make it burdensome, appreciate individuals, whether it's through small incentives, whether it's giving people back information. I mean, the other experience we've had is when people participate in research, they want to know what the results were. And that is another form of engagement where, you're not just dumping your data and you never hear back from the researchers. And that again is something that we've done over the years, which I do think adds a lot of value to the research and builds trust in the research when you have this back and forth.
Any other thoughts from the panelists? All right. We have another question that I think relates to the comments actually from all of our speakers. But so following up on the work presented on tumor testing and factors associated with referral and uptake of genetic evaluation and testing. So the comment is, we need universal approaches that don't stop after a test is done, but focus on systematic approaches, I should say, that consider the entire continuum of care, from testing to referral to genetic evaluation to surveillance. What strategies do you recommend for systematic approaches to achieve equity in these different processes? So big question. Any thoughts from the panelists?
Well, I think anytime you can automate any of these processes, you're going to have better luck. And we've seen in some of our research with universal tumor screening for Lynch syndrome, that's the case. The other thing is, based on what Tua had said, we need to make it easier for the patients. The places that have the best follow-up with universal tumor screening for Lynch syndrome are the ones that actually do that. They meet the patient at an appointment they're already having to follow up for their cancer. So anytime we can make things easier for the patient, we're gonna be better off. And anytime we can automate things. I think one of the reasons why a paper I found didn't find disparities between Black and white individuals when they were looking at their institution, because they were looking at individuals 50 and below, and there's a clear criteria in NCCN that 50 and below should be seen for genetic counseling and offered genetic testing. So I think anytime we can do any of that, it's gonna help the systems.
But beyond that, and this is something you've talked about a lot, Debbie, before in our conversations, stepped care, I think, is really important to consider, right? What we're going for is equity, not equality. So we need to meet people where they are. There are certain people that may be okay with the automated approach. And in our U01, that's kind of what we're doing as the first trial. But adapting that from our learnings is our plan to, what we think we're going to end up is, it will be okay for a proportion of people, but some people will need more in order to reach the same health outcome. And that's kind of where we have to, I think, start from, recognizing that some people will need more resources. They will need more navigation. they will need more support in order to want to be tested, in order to get the follow-up care they need. Debbie, I
In
don't
order
know
to
whether-
overcome all those systemic barriers, right?
Yep.
Because they have additional barriers and we may need additional things that we do. And that is our plan. We hope it works.
And, the goal of the initiative was really focused on a variety of strategies because we know, we need different strategies for different groups. When you consider that we don't have enough genetic counselors to go around, things like finding groups that automated referrals work for and processes work for allows you, as you said, to use other strategies to recruit groups that may be missed because we don't have the workforce, but don't have the resources either.
Kyle or Sonia, any other thoughts on that question?
Yeah, and I'll just add, I think navigation systems cannot be, overemphasized enough, because sometimes we really miss opportunities to really meet a patient whether that's insurance gaps that patient may be having, or they live in a rural area and not able to be coming in, and maybe transportation is their barrier. So I think sometimes it's time consuming. And of course, then you think about who's going to fund that, right? So I'm sure some of you may be thinking, but I think sometimes we really have to step back and try to figure out, why are we not able to truly give equitable care? Like, we're doing all the great things in this system, for example, but for some reason we're missing a big chunk of patients. And I think that's where we sometimes need to dial it back and truly try to figure out, who are we missing and why are we missing those patients, and how can we overcome that going forward?
And I'll just add one thing, just because it's an opportunity to highlight it, having members of the care team who have similar shared experiences to patients who are being served less well is another important way that we can help serve, groups that experience barriers to access. So that starts all the way back at training programs and really being intentional. And in the same way that Sonia was talking about being intentional in recruiting participants, being intentional about the way we recruit genetic counseling students and physicians and other folks who are going to be involved in the care team.
Great. We are coming up on our last few minutes, so just in light of the topic of today, Kyle, any thoughts that have come to you on how to think about incorporating measures that allow you to capture systemic racism or other aspects of racism? How would someone go about trying to think about selecting measures?
Yeah, that's a great question. I think the first step is really to figure out what's the concept that you need to get at. So, using the available literature, sociologists do a lot of this, figuring out in the kinds of things that I'm dealing with, what are the concepts that I need to capture? What are the domains I need to capture? And then, find validated measures. As I've learned more and more in this field, I've discovered measures that I never knew existed, but seem so helpful to me. Like there's measures of concentrated poverty that are based on census variables. There are measures related to the lived experience of interpersonal discrimination. So really think about, what do I need to get at, and keep an open mind about what are the measures that count. And in many cases that will likely mean moving outside of conventional health research, moving outside of PubMed, because as we've seen, not a lot there, right? But there are folks who have been doing really important work on these kinds of issues, and there are ways to measure it. We just need to look at their work and collaborate with them as well. Did that answer your question, Kim?
That very helpful, and yes, I would endorse the need to move outside of PubMed, because there's a lot of interesting things, just not necessarily from our fields. So I believe we are at time. I want to be sure to thank our speakers, our panelists, for this really interesting discussion, which we are hoping to continue through additional webinars. Thank you all for taking time out to attend and to give talks, and have a great rest of your afternoon.
Thank you. It's great doing this with you guys. You're